Thanks. While we're actually talking about telehealth, these are just a few more specific questions for anyone on the panel. What actually qualifies as teletherapy? That's one question. And also, what does the law tell us about telehealth? A lot of people have concern about crossing state lines and other things. And how do families and practitioners work through reimbursement-related issues? So that's yet another policy-oriented questions. I think these are perceived barriers, all of these, the law, reimbursement, and also I think people have some confusion about what exactly is teletherapy if we're talking about delivering interventions. So for anybody who wishes to address.
Well, there are a broad spectrum of teletherapies. There's face-to-face, pretty much a precise imitation of what would happen if someone were in the same room. There's synchronous passage of messages, so people could in fact do texting-related therapies. There's asynchronous, where in fact one can either send video messages back and forth in terms of response to various, or intervening in an asynchronous fashion, but with video present. There's audio teletherapy, which existed just with telephones before we had smartphones, and continues to exist. And anything that uses those tools in the broadest possible spectrum would allow that kind of intervention.
Thanks for that, and that actually speaks a little bit to the asynchronous and synchronous use, but yes, Oliver.
So Shelley, thank you. So just a couple of data points from other countries around the world. Switzerland was one of the first adopters of telecare, not just for mental health disorders, but for a range of medical disorders. And it's very, very common now, I think maybe becoming more common than a primary care consultation face-to-face. There's also a telecare service which covers most of Latin America, centered on Brazil, called SaluSpot, which has 20 million patients and 30,000 physicians on the back end. So more driven by necessity, largely the long distances to travel and the dearth of practicing clinicians. A lot of other countries, particularly in the developing world, have kind of leapfrogged over existing healthcare systems in the West and have adopted telecare kind of wholeheartedly.
So thank you for that, Ken.
The state lines is a thing, right? So if you're seeing a kid at Duke, you're technically practicing medicine in North Carolina. So I think the professional societies have to figure out how to help people with that barrier. It is actually a true barrier. It is, like all these other equations, solvable. It takes clarity of purpose. The states would have to collaborate. I know there's some New England state activity in the social work field to think about that differently. And until that happens, national companies are coming in with people that are licensed in every state, which is another way to do it. It's another disruptive idea. It's a field that could use a little disruption. And that's an interesting, I think, potential opportunity.
I took a look at the several of the online platforms prior to this conference, and the subscription services for therapy are quite interesting because they have also different billing practices depending on how long the session, if you decide that you will have a 3-pack therapy package that you'll purchase and so forth. So as we get into this disruptive technology, it's also the case that it may be disruptive to our customary practices around billing and our way that we think about what constitutes a session and what kind of commitment a patient might need to make.
So thanks for those comments. I want to shift focus just a little bit and maybe have Kim and Gary from your perspectives talk a little bit about the impact of stigma and cultural barriers, about accessing mental health care globally. And I know, Kim, some of your comments alluded to this. How are we going to overcome those in terms of some of our digital and technological applications to delivering mental health care?
So it's both the medium as well as the content. So we have a way to deliver care at scale and remotely. But if the care package is not culturally sensitive, I think that level of engagement will be much decreased. So I think about some of the work of Maggie Alegria, who has pioneered the use of a short-term CBT approach specific to, or taking into consideration the interest and needs of Latina women. It's been delivered over the telephone, over cell phones. I don't know if there's a video version or not, but it's proving to be just as effective as in-person treatment. But it's not the medium that is really driving the outcomes exclusively. It's that the treatment itself has been designed for the population that she's most trying to reach.
So in the developing world, first, it's not just a societal and religious stigma and a local stigma, but also a policy stigma and the isolation of people with mental illness from the mainstream in terms of decision-making and empowerment. At the same time, the lack of services causes such tragedy to families that families become advocates. So in many places in which we are, there are very, very small, centralized, extraordinarily inhumane and frightening mental institutions that keep people in circumstances worse than bedlam and without any hope of real therapy, treatment, or other intervention.